Okay, hello and welcome to today's webinar, Shed Meds, a patient-centered deprescribing trial. This webinar is sponsored by the U.S. Deprescribing Research Network with funding from the National Institute on Aging. My name is Ken Bookvar and I'm your host with Jen Chia. I am a geriatrician and health services researcher at Mount Sinai in New York and the Bronx VA GRAC. Before we get started, a few technical details. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. So unless you are logged in as the host or panelist, your line is muted. But we do welcome and encourage audience participation using the Q&A feature of the Zoom webinar. When you would like to interact with the presenter, click on the Q&A bubble icon on the bottom toolbar and type your questions into the box. If you would like your question to be anonymous, you can check in the anonymous box before sending. Hosts will acknowledge questions during the final 15 to 20 minutes of the webinar. Also, after the webinar, you will receive an email with a short evaluation survey. If you're having technical or logistical questions, we ask that you submit those using the chat box to our co-host, Jonathan Norton. Please make sure that you are identified by either name or participant ID so that our webinar host will be able to help troubleshoot any problem you're having with audio or other issues. And a big thank you to Jonathan Norton at Johns Hopkins, as well as Milena Spar and Nail Rizzo at UCSF, doing amazing work behind the scenes to make these webinars possible. Now for our presenters. Dr. Eduard Vasilevskis is an associate professor of medicine at Vanderbilt University Medical Center and a staff physician with the Tennessee Valley VA Geriatric Research Education and Clinical Care Center. Dr. Vasilevskis' research has focused on the care of the older hospitalized patient, including post-acute care transitions and delirium care. Most recently, Dr. Vasilevskis has been co-PI for a randomized trial that is investigating the medication and geriatric syndrome outcomes of a patient-centered medication deprescribing protocol, Shed Meds, which you'll hear about today. Our second presenter is Dr. Sandra Simmons, who is a professor of medicine in the Division of Geriatrics at Vanderbilt University Medical Center and director of the Center for Quality Aging. She is a co-leader of the U.S. Deprescribing Research Network Pilot Corps, and she also currently serves as a co-principal investigator for 2 randomized controlled trials to determine the impact of a deprescribing intervention on medication burden and health outcomes among hospitalized older adults. Please welcome Dr. Vasilevskis and Dr. Simmons.
Great, thank you so much for those introductions. Welcome everybody, thank you for spending your lunchtime hour with us to talk about Shed Meds, the patient-centered deprescribing trial. I do want to acknowledge I don't have a conflict of interest slide on here, but neither Dr. Simmons nor myself have a conflict of interest. And also just want to acknowledge funding from the NIH, the NIA for this Shed Meds patient deprescribing trial. So today I'm going to give you a little bit of a background about how we got here to this deprescribing trial among hospitalized older patients going to post-acute care. And it originates in a study called Impact Interact, which was a CMS Innovations Award. I'm going to talk about a pilot deprescribing study that we did near the end of that, which really led to some kind of questions and knowledge gaps that we hope to address with this current ongoing trial called Shed Meds. Among Shed Meds, I'm going to talk a little about the study methods, some of the lessons that we've learned thus far, and some of the next steps that we're hoping to learn, but also the purpose of this is to really help others learn about these next steps, and hopefully others can join us as well. So first, I'm going to talk about a background. In the 2010s, we were engaged in a study called Impact Interact. This was a CMS-funded quality improvement. It was not a randomized trial, but it was a quality improvement intervention focused among older hospitalized patients who are going to post-acute care settings. we recognize that those patients in the hospital are often transitioned to the post-acute care setting with inadequate information, with an inadequate understanding of their healthcare condition, and poor transitional information of their medications. The goal of this trial was really to try to reduce post-acute care readmissions as well as adverse outcomes in the post-acute care setting. So within this CMS transitional model, what did we do? A couple of unique things that we did in the context of this quality improvement trial was we systematically identified geriatric syndromes. We looked at a number of geriatric syndromes, in fact about 7, including things like dementia, delirium, falls, pressure ulcers, and depression. In addition, we focused on gold standard medication reconciliation at hospital discharge. What we found was at our hospital, and this was not alone, we found in other hospitals, was that the amount of information that was getting the post-acute care settings was variable. And the post-acute care settings were unclear about what medications the patients were taking and what to do with those medications, which ones to continue, which ones to stop. And so we came up with a really solid medication management plan. We also provided advanced care planning review, as well as a rehospitalization review if those patients came back. So what did we find out? Well, despite all of our efforts to try to improve documentation and measurement of geriatric syndromes, improve the transition of the information to the post-acute care setting using warm handoffs, and using gold standard medication reconciliation, we only had modest improvements in 30-day readmission. But what we did find was that our patients who were transitioning from the hospital to the post-acute care setting had a very large burden of geriatric syndromes. And in fact, 55% of them had 3 or more of the 7 geriatric syndromes that we measured. In addition, what we found was patients who were transitioning to the post-acute care setting had a very large medication burden. 98% of these patients met criteria for polypharmacy. That would be 5 or more medications at the time of hospital discharge. 83% of these patients met criteria for hyperpolypharmacy. And these were Medicare 65 and year older patients going to post-acute care. The average number of medications at hospital discharge was 14, and the average number at skilled nursing facility discharge was 15. One can see the box below. This is focused exclusively on potentially inappropriate medications as measured by the Beers-List criteria. What we found is that patients on admission had, on average, 2.2 medications that were potentially inappropriate medications. Each patient had an average of 1 medication that was added, but at hospital discharge, they had the same number of medications that were potentially inappropriate. So the burden was relatively high for these Beers-List criteria. So at the end of this trial, what we were considering was, here we have a population that's very frail and fragile, has 3 or more geriatric syndromes, and they're on a very large burden of medications. And although we focused on gold standard medication reconciliation, we actually did not make efforts to try to reduce or tailor those medications to what was appropriate. At that time, we were really trying to get the right list, make sure that the 14 medicines that they were transitioned on, that information got to the post-acute care setting, and that there was a plan for each one of those medications so the skilled nursing facilities would know what they were on, why they were on it, and what should be done. However, when we noticed that indeed at skilled nursing facility discharge, they were on 15 instead of 14 medications, and with the burden of geriatric syndromes, it brought up the notion of the prescribing cascade. Was it possible that these patients were on 14 medications? Some of those medications were added because of geriatric syndromes, and some of the geriatric syndromes were occurring because the medications were added, creating a cyclical prescribing cascade. When considering this, near the end of our CMS study, we decided to do a pilot study of deprescribing. This was really a feasibility study. We wanted to know, in a small number of patients in the hospital, among these patients going to skilled nursing facilities, could we successfully deprescribe medications? Importantly for us, deprescribing means a reduction in dose as well as termination of medications. This was a non-randomized historical control pilot. These were patients that were discharged to skilled nursing facilities, but the deprescribing occurred exclusively within the hospital. And we took 20 patients and we utilized a pharmacist or an advanced practice provider and did a rigorous review of their medication list and tried to attempt a patient-centered deprescribing protocol. You can see on the right our acronym SHED MEDS, M-E-D-S. The first step, we did the gold standard medication reconciliation and confirmed that we had all the medications that we thought the patient was on, either before the hospital or during the hospital. We evaluated each of these medications for deprescribing, and I'll talk a little bit about that framework moving forward when we talk about the overall trial. We then worked with the patient to decide which medications between us and the patient, as well as their providers, do we think were the most important ones to deprescribe, if any at all. And then we synthesized those recommendations and spread those recommendations to the primary prescribers, the patients, their caregivers, and the primary team. Well, what did we find after doing this small 20-patient study of deprescribing? Well, one is we found that it was feasible. We could reduce medications among patients in the hospital or going to post-acute care facilities. I don't show numbers here, but on average, we were able to reduce between 1 and 2 medications among patients in the intervention arm compared to the cohort from the same study. What we also found was that we were more successful in reducing potentially inappropriate medications as well as medications associated with geriatric syndromes, albeit feasibility was the most important part of our trial. What we found was patient engagement was key. I don't show data here, but among the recommendations, a majority of those recommendations were changed on the basis of conversations with patients or their providers. So although we did successfully deprescribe in this pilot, the final deprescribing actions were actually different than what we had proposed when we did the initial medication review. We also recognized that we had a very short period of time to make these recommendations, and because we didn't continue in the post-acute care facility, we thought that perhaps if we could continue deprescribing in the skilled nursing facility, we may have more efficacy. In addition, we might be able to address one of the barriers for both patients as well as providers, and that is what's going to happen when we deprescribe our medications. If we could utilize that time in the skilled nursing facility to follow our patients, perhaps we would get more buy-in from patients and providers to allow us to deprescribe when we thought it was inappropriate or when we had equipoise. And finally, of course, this trial helped lay the groundwork to assess effects on outcomes on deprescribing. Within the CMS study, we were already measuring geriatric syndromes. However, in review of the literature, what we found was there was very little understanding about the effect of deprescribing on these important outcomes that we were trying to transmit to the post-acute care setting. So this leads us to some of the questions that we were trying to come up with and try to answer within the context of SHED MEDS, our current deprescribing trial. This led to the question of what are the knowledge gaps? What interventions currently exist? Well, in review of the literature, and when we were trying to design our overall SHED MEDS deprescribing intervention, what we found was most deprescribing that was occurred in the primary care settings. There are a couple of small inpatient studies which tried to attempt deprescribing within the context of the hospital care setting. And we can talk a little bit later in terms of is the hospital setting the right setting. The next what we noticed was that the majority of deprescribing studies utilize explicit criteria. That is, using lists such as the Beers list or the STOP criteria as pure identification for a means to deprescribe. If they had a medication on this list, perhaps we should deprescribe this medicine. We looked to expand this list and we created something called the Medications Associated with Geriatric Syndromes, recognizing that there's a number of medications which might be contributing to geriatric syndromes which are not on these lists. And in addition, we thought that there are additional medications which may not have an indication or that the patients may have challenges in terms of taking with adherence that we would potentially be able to deprescribe. And this leads to the third bullet point, and that is many deprescribing trials are focused on a specific drug class or disease. We thought it would be important to take a holistic approach and really deprescribe across all the classes of medications, considering where our patients are, what their conditions are, and where they're going. Other factors that we noticed that we thought we'd be able to add to the data and body evidence for deprescribing was this notion of deprescribing in the acute care, but also going on to the post-acute care setting. As mentioned before, a barrier to deprescribing sometimes is the fear for what might happen when a patient has a medication that's either stopped or decreased in dose. The notion of being able to continue this in the skilled nursing facility was novel, and really helped us to address one of those major barriers. In addition, the impact on outcomes. We decided up front that we wanted to really treat, in addition to know what was the impact on medications and medication burden, we wanted to track those outcomes, including geriatric syndromes, to understand we know that polypharmacy is bad. We know that polypharmacy is associated with multiple geriatric syndromes, but nobody actually knows if deprescribing is good, if deprescribing reduces or ameliorates geriatric syndromes. Finally, we sought to really try to create a generalizable approach. We are enrolling patients across the entire hospitalized setting. It is not medicine patients, it is not surgical patients. We are focused, of course, on frail patients going to post-acute care setting, but we take all these patients across our entire hospital, and we're looking at the entire spectrum of medications. And then finally, the assessment of barriers and facilitators. I'm not going to talk much about this from a context of patient barriers and provider barriers, but talk more about this from a system of implementation of deprescribing itself in the system. So the focus of our NIH-NIA funded R01 study was really to take patients in the hospital, perform a holistic deprescribing approach that was patient-centered, moving beyond explicit criteria, and really looking at the entire focus, the entire expanse of medications that our patients might be taking. So let's now move to the actual trial itself, SHEDMEDS, a patient-centered trial of deprescribing. It's one of my favorite cartoons, and maybe we'll find this, maybe not. So what is SHEDMEDS? So SHEDMEDS is a 5-year randomized controlled trial. We started enrollment in 2017, and we're in our final year of enrollment right now. The primary aim of SHEDMEDS was to reduce the number of medications patients are prescribed at both Vanderbilt University Medical Center, as well as skilled nursing facility discharge. And we look up to 90 days to see if those reduction medications are sustainable across that period of time. Next, we document the intervention effects upon a number of geriatric syndromes, which I'll highlight in a future slide, trying to understand whether deprescribing impacts those geriatric syndromes, as well as adherence to medications and functional health status. So who are we enrolling? We're enrolling patients who are 50 years and older of age. They must be on 5 or more pre-hospital medications. They must be discharged to one of 22 partnered skilled nursing facilities that we are working with. And that is because, as mentioned before, we continue the active deprescribing into the post-acute care setting. Patients must live within a 9-county area of Vanderbilt University Medical Center because we do a home visit at 90 days. Patients cannot be enrolled in hospice on admission to the hospital, and they must be admitted from the community setting. They can't come from another acute care facility or from a nursing home. Assisted living facilities are okay. And finally, a patient must be able to consent or have a surrogate to be able to consent on their behalf. So let's take a little look about who we've enrolled thus far. This is some preliminary data as of 2019. You can see that the majority of our patients are female. The majority are non-Hispanic. 15% of our patients are African American. And the mean age is 76 years with a standard deviation of 11. Importantly, 98.8% of our patients are on 10 or more medications. If we recall the original pilot study that we had done, among those patients, only about 83% of our patients were on 10 or more. So our patients in this trial are much sicker and have a higher medication burden. And the comorbidity index in this trial is 6.9 using the Charleston Comorbidity Index. Once again, recalling our pilot study from the Center for Medicare and Medicare Services, our comorbidity index was only 3 to 4. So once again, our patients have gotten sicker within the context of the UMC, and that's important as we discuss some of the barriers a little bit later on. So this is just a map showing the regional area of our skilled nursing facilities that we work with. When we enroll a patient, we will enroll a patient who has been referred to one of these 22 facilities. Why focus on skilled nursing facilities? Well, first of all, this is a very important population among Medicare patients who are discharged. We know that 33% of older patients in Medicare receive some form of post-acute care services. In addition, as mentioned before, this was really addressing one of our primary deprescribing barriers, and that is the ability to monitor as well as continue to deprescribe as we move throughout the post-acute care process. As mentioned, we have 22 partner skilled nursing facilities as well as rehab facilities as well. So this just shows the SHED-MED study timeline. It's broken up into 4 phases. The first phase is our consent phase. Patients are referred to us, and we screen them if they've been referred to skilled nursing facilities. We look to them for consent. And every one of our patients who are consented get a pre-admission, a pre-intervention interview. I'll talk about the measures that we do, including the geriatric syndromes. And then after that point, they're randomized to either the intervention, that is a patient-centered deprescribing, or the control. All of our patients do get gold standard med reconciliation at the time of hospital admission as well as hospital discharge. As they're moving throughout the hospital, we review those medications, we make deprescribing recommendations, and then they transition to the skilled nursing facility, and we provide that skilled nursing facility with the medication management information. In phase 3, we continue to deprescribe for our patients in the intervention arm, and the control arms just receive standard nursing facility care. Our intervention stops at the point of skilled nursing facility discharge. So deprescribing continues all throughout the hospital and skilled nursing facility. And this is just continued, usually not new recommendations in the skilled nursing facility, but continuing deprescribing dose reductions of the initial recommendations we made at the hospital discharge. Phase 4 is follow-up. We have a phone call at day 7, day 60, and at day 90, we have an in-house visit where we review their medications, repeat the geriatric syndromes, and assess their medications. So what are the measures that we're looking for? First of all, we of course look at every single medication that patients are admitted on. We look at the type of medication, the name, the route, the dose, and the frequency. As mentioned before, from our standpoint, the definition of deprescribing is not just the termination of a medication, it's also a dose reduction of a medication. We look at the medications associated with geriatric syndromes. This was a list that we had created and published in the Journal of Hospital Medicine, moving beyond the PIMS and the Beers list and the STOP criteria to account for additional medications which may be appropriate in some contexts, but considering geriatric syndromes may be inappropriate. We did look at the Beers list, STOP list, and RASP list criteria, which we identify as PIMS. And we follow a drug burden index, which is really a quantification of the burden of anticholinergic and sedative burden among our patients. We look at safety measures as well. We follow drug-related adverse events. This includes both the addition of drugs as well as drug withdrawal events. And we monitor patients for ED visits, hospital utilization, and mortality all the way throughout all phases of the intervention. This just shows a list of the various measures that we get upon the interview. In terms of interview 1, after they've been consented and after they've been randomized. All of our patients have the following geriatric syndromes, which are measured using standardized tools, which are listed on the second column. So all of our patients are assessed for delirium, cognitive impairment, depression, urinary incontinence, weight loss, pain, pressure ulcers, and falls. We additionally look at additional outcomes among all of our patients, including functional status, medication adherence, as well as patient attitudes towards deprescribing. Next, I'm going to go through our actual intervention. What do we do when we do a patient-centered deprescribing? And this just gives you a notion of the framework that we use when we're approaching medications and their medications to decide, is this a medication that we want to propose to the patient as being potentially appropriate for deprescribing? We look at patient and disease factors, and we look at medication-specific factors. Among the patient factors, what are their goals of care? What is the risk-benefit? What is the cost of the medication to the patient? Are they adherent to the medications? And are the medications, do they have appropriate treatment targets for the age or the condition or the stage of the illness of the patient? And then we look at medication-specific factors. Are there drug safety profiles that we need to consider? Drug-drug interactions, drug-disease interactions, or any concerns for drug withdrawals. This just shows the various steps for deprescribing, and this would be for all of our patients who are in the intervention arm. And I'm going to take you through all the way from the beginning of the baseline patient interview, all the way to the N for which we're deprescribing at the time of hospital discharge and throughout the SNF. So the first step that we do is a baseline patient interview. Remember, we get referred patients when they get referred to a skilled nursing facility. So we do not see patients throughout their entire hospital stay. In fact, we generally see the patients later in their hospital stay when the primary treatment team has decided the patient would receive benefit by going to a post-acute care facility for ongoing treatment of their medical conditions. The baseline patient interview, the most important part of the interview, in addition to the geriatric syndromes, as well as those other measures which I just highlighted, is a gold standard medication reconciliation and an understanding of all their medications that they were taking before they got to the hospital, as well as all their medications while they were in the hospital. This next slide just shows a notion of our framework for our gold standard medication reconciliation. Importantly, among all of our patients, we look at the medical records. We find out what medications were listed as pre-admission medications before they got in the hospital. Importantly, we recognize that that list that the team is using in the hospital may not be completely accurate. So to try to fill out this list and get the most accurate possible list that we can, we speak to the patients and ask about additional medicines. We speak to their caregivers. And we also find out which pharmacies have you used in the last 6 months. And on average, our patients are using 2 to 3 pharmacies to get their medications. We reach out to each of those pharmacies and we try to find any additional medications that they might be using and add that to the pre-medication list. In addition, we look at in-hospital medications that they might be receiving right now and may be continued into the post-acute care facility. So our enrollment medication list is really any medication which has the potential to be continued in the post-acute care or even after post-acute care. So the pre-admission plus in-hospital medications. This next slide just shows some preliminary data about why it's so important when you're doing a deprescribing trial in the hospital setting to do the additional work to get this gold standard medication reconciliation list, excuse me. You'll notice below in the table, this just shows the number of medications that our team finds when they're going out and calling the additional pharmacies. So on average, patients have an average of 1 additional medicine that we find from pharmacy refill data that was not present on the pre-admission medication list from the hospital. When we talk to the patients and their surrogates, we find another medication. And then finally, when we look at additional medical records, we find a half a medication. You'll see in the chart above in the figure, this just gives you an idea of what medications do we find. Now, some of them may not be super relevant to things like geriatric syndromes, things like acetaminophen or vitamin D. However, some of these medications might be very important from the context of the care of their primary medication, their primary medical problems, or from a geriatric syndrome and functional status standpoint. So things like gabapentin, furosemide, tramadol, oxycodone, Miralax. So after getting this complete list of medications by calling pharmacies, talking to patients, talking to their families, our nurse practitioners or pharmacists do a review before we go and talk to the patients. And the review is really trying to identify medications that we think, from looking at the medication list, from looking at our deprescribing framework and looking at the medication record, which ones do we think are potentially appropriate for deprescribing. For each of the medications, if we believe that a medication can or should be deprescribed, we will classify the medications to some of the appropriate, to some of the following classifications. So first is, we look to see, is there an indication for the medication? A surprising number of medications that our patients are admitted with. From looking through the medical chart, we do not understand why this patient is on the medication. And that would be one that we would flag for potential deprescribing. This is before we've talked to the patient. Next, we look to see, are they on the appropriate dose of the medication? Third, we would look to see, they're on the medication, we can see what the indication is, but maybe the indication is inappropriate for the medication they're on. This is a medication they're using for anxiety, but this actually is not a medication classified for anxiety. This is a medication that was prescribed for sleep, but we do not believe that is appropriate for sleep. Fourth, we try to find if it's the medication is ineffective, as evidenced by no change in symptoms or condition. A patient might be on a particular medication to treat depression or pain, but from the indications in the chart, we can't see if it's being effective at this point. Next, we look to see if there's duplication of medications for the same indication. A number of our patients are on multiple antidepressants. A number of them on multiple antihypertensives, multiple anti-diabetic drugs. And the question is, can we potentially consolidate these medications to fewer medications? Next, we look at high-risk medications. And these medications might be based on, first, is there a potential drug-drug interaction or drug-disease interaction? And what are the common interactions that we're commonly looking for? Well, one, chronic kidney disease, chronic liver disease. This is something that we see quite commonly in our older patients. And in addition, we look at that list that we've created, the medications associated geriatric syndromes, because we know a large number of our patients who are admitted from the hospital may have been admitted, for example, for falls. So we call out to our deprescribers, hey, this medication has been for falls. And if we see a link between their admission diagnosis and the medication associated geriatric syndrome, this might be an opportunity or consideration for deprescribing. In addition to these, of course, we look at the explicit list, the explicit criteria, which are very well validated, the Beers list, the STOP list, and the RASP list, which would be all explicit, potentially inappropriate medications. Next, we try to find out, are the medications inconsistent with the goals of care as much as we can tell from reviewing the chart. We, of course, reconsider this in terms when we do the patient interview. We do try to understand the patient's life expectancy on the basis of estimated benefit from a Charlson comorbidity score and other risk factors, and try to understand, do we think this medication would be beneficial given the expectancy of our patient? We try to look if there's any evidence of poor adherence, either from the pharmacy refill data that we got from the medical records or from the medical record itself. And then finally, we try to understand, was this medication started for one reason, but we can tell it was supposed to be time limited, but it's still continuing at this point, and we think it's going to resolve. We, of course, look at specific disease benefit to harm thresholds, which may support treatment at one point in time in the patient's lifetime, but maybe not right now. Common ones that we look at are aspirin for primary prevention, trying to terminate those after age 70, statins for primary prevention after age 75, bisphosphonates, have they been on them for more than 5 years? We look at blood pressure targets, A1C targets, as well as the stage of disease to try to understand if they're matching from what's known in guidelines. So that is a lot of work that our pharmacists or nurse practitioners are doing to try to tee up the conversation with our patients to have the patient preference interview. So when we reach our patients, we have an idea of the medications that we may want to deprescribe, but we will not make any deprescribing decisions without having a conversation with our patients first. We first try to assess their medication knowledge, adherence, side effects, preferences for stopping specific medications, and willingness to decrease dose for specific medications. And so really what we're getting at is moving beyond explicit criteria and really going to a patient preference interview and patient-centered deprescribing. This just gives you a notion of some of the introductory questions that we do for our patients when we're having that second interview with them after we review their medications. So asking them, do your medications cause side effects? You can see none, a little, a lot, and they may identify specific medications which we may focus on in our next conversation. Is it hard to remember the doses of your medications? Is it hard to pay for your medications? Is it hard to open the container? Is it hard to get refills? Is it hard to read the print? Are the dosage times inconvenient? Or are there other problems? And so trying to just trigger some ideas about, from their perspective, are there medications that they see as problematic, that they see as causing symptoms, that they see as being costly, or they're having troubles with adherence with? Because we may have identified 15 medications that we think are potentially deprescribed, but we really want to focus our deprescribing on the ones that the patient identifies first. Once we have our priorities and the patient's priorities, we will go through one by one the medications for deprescribing. We may not get to all of them, but we're clearly going to go on the highest priority ones from our perspective as well as the patient perspective. And this just shows you kind of a questionnaire based on the brief medication questionnaire of the types of questions that we ask for each of the medications. Do you know why you're taking it? We have found this. Do you understand what the medication is for? How well does this work for you? How much does it bother you? Have you missed taking the medication in the last 3 months? Have you stopped taking it in the last 3 months? If so, why? Is it a cost issue? Is it because you were symptomatic? And what happened when you stopped it? Did you feel better? Did you feel worse? And then we would ask them for those medications, are they willing to deprescribe the medication? Are they willing to reduce it? Are they willing to stop it? And that's a really important for us. One of the notions for deprescribing from a patient perspective, there might be a lot of fear of stopping a medicine, but we're just as interested in reducing dose as we are in reducing the overall medication, especially when looking at the literature for things like the drug burden index or anticholinergic burden, that we know dose matters. So if we can reduce the dose, we might be able to alleviate some of those concerns of the fear of stopping a medicine, say, hey, why don't we stop at 25% and see how things go? You can see at the bottom, we also have a box. If a patient is unwilling to deprescribe a medicine that we would like to deprescribe, we have a list of barriers. And then if they're willing to deprescribe it, we have a list of enablers. We could have a whole hour-long conversation about the barriers and enablers from a patient perspective to deprescribing. I'm not going to talk about those now. Sandra Simmons and Amanda Mixon are doing another trial at the VA called DropMed, and that trial really is focused on honing in on some of these barriers and enablers. And so I hope we have an opportunity to come back and talk to you about those in the future. So now we've had our patient conversations, and from the list that we had, in having the conversation with them, we will come up with a decision about which ones would we like to deprescribe that we have buy-in from our patients that they are also willing to deprescribe, either reduce the dose or stop the medication. But we're not done. From this standpoint, one other kind of concern from a patient perspective is, I don't want to do it unless my doctor knows about it. So we make every effort possible to talk to both the inpatient team that's responsible for prescribing, but also contacting their outpatient providers who may have been the primary prescribers. Another really important reason to call the pharmacies is that we can get all the prescriber information. We know who prescribed the medicine in the first place. So that medicine that we want to deprescribe, we can reach out to that individual to have a conversation if they were willing. Sometimes they're not willing. We will not deprescribe a medicine that we think is going to be restarted in the outpatient after they get discharged in the outpatient arena. But other times they might say, oh my goodness, I've been meaning to reduce or stop that medication for some time. Thank you for doing that. So we have our provider discussion. So now the patient's agreeable, the providers are agreeable, and then we make a final deprescribing action. When we talk to the providers, as you can imagine, the conversations can go in many different directions. We have kind of prepped conversations when we meet with them. We talk about the rationale of why we think this medication should be deprescribed. We mention obviously our conversation with the patient. And then depending on what the providers say, we put some notes down about either why they wanted it deprescribed or why they did not want it. And once again, the barriers and enablers is a whole nother conversation that we could spend a whole bunch of time, and I hope we can come back and talk about those. So now we've talked to the providers, we've talked with the patient, and it's time to make deprescribing actions. And deprescribing, as mentioned before, is not just one thing. We can stop a medication now. Once again, we have the advantage to go to the skilled nursing facility, so we can stop and monitor in the skilled nursing facility. We can say we would like this stopped later once they reach the skilled nursing facility and specify that time. We can do titrations, and we obviously recommend titrations for certain medications for which that's the safest course of action. We can say we just want to decrease the dose, or we might want to decrease the dose and specify further monitoring. So we will specify one of these actions for each of the medicines that we decide we want to deprescribe. And of course, we don't deprescribe a lot of medications. We may continue them, some medications are added, and some might be on hold that actually need to be restarted, and that's part of medication reconciliation. And that's important that we thought as part of this trial is that both at admission and discharge, we really try to do the best job of med reconciliation because we want to understand if there's any difference in outcomes, it's not because of med reconciliation. We do that for both intervention and control arms. It's going to be because of deprescribing and deprescribing actions that we make. So finally, our patients, of course, end up going to the skilled nursing facility. When they go to a skilled nursing facility, our nurse practitioners or pharmacists will do a warm handoff as a person-to-person conversation with the skilled nursing facility provider. We ensure what the medication list is, and we communicate those deprescribing recommendations, what we want done, why it was done, and what kind of monitoring should be done. We do weekly phone calls with the prescriber at the skilled nursing facility. We ask for the medication administration record at the skilled nursing facility to see, Are any new medications added? And we try to understand, if so, why, and what the rationale was. And it's an opportunity for us to continue titrations and continue deprescribing for medications that we already had agreement from our patients as well as providers. So once the patient's discharged from the skilled nursing facility, which could be as short as 7 days, as many as 21 days, at the time of discharge, that's when we will come up with the final discharge list. Because there have been so many changes from the hospital from the end of post-acute care, we create what we believe is a kind of a gold standard medication reconciliation list, and we provide those to all the primary prescribers in the outpatient setting. We indicate what's been stopped, why it's been stopped, why it's been started, why it's been stopped, and also give some recommendations about future deprescribing that they might want to do. Importantly, you'll notice in the last bullet, we cancel refills for those medications that we've been successfully able to deprescribe. What we don't want to have happen is patients go home, we've deprescribed that medication, and now the refills start coming back in the mail over the next 90 days. So next, I'm going to talk about some of the lessons learned and some of the implementation considerations. So first of all, we screen a whole bunch of patients, almost 8,000 patients. The number one reason that we don't see patients is because they're out of our county area. Once again, we're only working with 22 skilled nursing facilities, and our patients are referred from all over, and we need to do a home visit, and that can be a logistical challenge to go outside that county area. Next were, patients may have been referred initially to our skilled nursing facility, but even among those eligible, sometimes they were referred to ours, but at the time of discharge, they went somewhere else. 29% of times they were referred to our skilled nursing facility we're working with, but then they ended up going home. We do need a certain amount of time to do this deprescribing. It takes a lot of work. We recommend upwards of 48 hours to do the assessments, the interviews, deprescribing decisions, and to communicate, obviously, with the post-acute care setting. And so a quarter of our patients, we don't have enough time to work with. And then, of course, sometimes patients are transferred to other long-term acute care settings or other hospitals. So importantly, those patients that do meet enrollment and do meet inclusion criteria, our team is unbelievable. They're able to approach and screen 95% of these patients for participation. Our consent rate has been lower than what we have anticipated. We have a 31% consent rate. We thought it was a lot harder. We have been collecting some reasons for refusal, and I'll talk about those in a second, and some of the challenges of doing deprescribing in the hospitalized setting. So 71% of our patients were refused by the patient or family, 19% were undecided at the time of discharge, we couldn't enroll them, and 10% of our patients, we couldn't consent them, they were unable, we could not find an appropriate surrogate. Let's focus on the refusals. Among those 71%, the overwhelming number of patients refused, if you look at that bottom bar, is because I'm too overwhelmed. There's just too much going on with my healthcare right now. I can't focus on deprescribing. If you remember, our medication burden is even higher for this than our pilot was. 98% of them have 10 or more medications, and our CHARS and comorbidity index is double. So our patients really are sicker. They're going through more than what they were in our pilot. You'll see another group of the challenges are, for instance, my doctor already reduced the medications I take. I don't want my doctor changing my medications. I'm not interested in participating, and I'm uncomfortable with my meds, and I don't want to make changes. We make every effort to let people know, you don't have to be comfortable with this. You can, in fact, this is patient-centered. If you don't want to deprescribe, we're not going to deprescribe those medications. But even regardless, some patients still do not want to enroll. So what are some future directions? What are some things that can make this easy? Of course, this is very labor intensive. We're doing this majority by hand. We're reviewing the medical record. And clearly there's opportunities here for clinical decision support. Clinical decision support of linking geriatric syndromes with medications. So not just saying a medication is associated with fall, but hey, your patient had a fall. You might want to look at these medications that might be associated with and see if there's an opportunity for deprescribing. Being able to talk about life expectancy and understanding what their burden of illness is when making these decisions. Framing these deprescribing is also an area of real importance. How do you get people engaged? How do you introduce the notion of deprescribing? And also, how do you answer their questions for deprescribing? And those are definitely areas that people should be focusing on moving forward. The setting, we do not know if the hospital is the best setting. And in fact, as you can see, we have seen some challenges with patients too sick. But We do know that the hospital is a wonderful opportunity where patients have a particular illness, especially when it's linked to a geriatric syndrome or condition, to be able to say, hey, you had a bunch of falls and you're on 5 medications with falls. This might be the right setting. But there are other settings that people can look at that are ripe for potential deprescribing. The skilled nursing facility, long-term acute care facilities, and also kind of assisted living facilities. So there's lots of different places where we might be able to accomplish deprescribing. And then finally, this notion of care transitions. We're only focusing on one transition of care to deprescribe. But clearly, there are opportunities when the patient leaves a skilled nursing facility that a lot can happen between skilled nursing facility discharge in 90 days. And following patients across transitions, I think, is really important with regards to being able to be successful with care transitions. And I think we're going to learn a lot about this moving forward. I want to acknowledge our ShedMeds team. They're an amazing group of clinicians and researchers. This could not be done without them. Our project coordinators, who are also really good at helping make slides, by the way. Our geriatric nurse practitioners and pharmacists who do all of the deprescribing that is done here. And then, of course, our research staff who makes countless phone calls to pharmacies, countless phone calls to patients and surrogates in helping us in the consenting process. So I just want to thank you. With that, I will conclude.
Great.
Thank you very much. Thanks, Dr. Vasilevskis, and for that amazing presentation walking us through the backstory and the development of the questions. Now it's time for questions that you may have. So feel free to click on the Q&A bubble icon on the bottom of the toolbar and type your questions in the box.
And by the way, my team is standing by, so it will not just be me answering questions. I am a part of the team, and others may have a lot of insights about these answers. So I invite Dr. Simmons, as well as the rest of the team members who are close by.
Excellent. So we have one question here. How are you providing patient caregivers education, either in ShedMeds or in your previous study? And if you are, what is the evidence-based educational materials that you are sharing?
So with regards to education, we have created a kind of a list of frequently asked questions and have talked about it a lot with regards to team meetings. But that is an area we do not have an educational pamphlet or an educational intervention to be able to further. So most of the education we are doing is at the bedside. The same rationale that we provide, that we come up with the deprescribing, we will provide those rationales and let them know, hey, this is why we thought this might be an appropriate medication to deprescribe. We will teach them about the guidelines for primary prevention for coronary artery disease, or the guidelines for hemoglobin A1C in the management of older patients and their diabetic care. And so we will, this conversation that we have, and I would love to invite folks in the room, takes a long time to do Q&A. So our education really is a tremendous amount of time at the bedside. And I think that subjectively what has been noticed is the more time we spend at the bedside having that conversation, the better success we have at deprescribing.
Thank you. We have another question from Alana Breckenridge. And the question is, what is the RASP list, RASP list?
Good question. So the RASP list it's another list which is basically, it's out of Australia and it's based on very close alignment with the STOP and the Beers list criteria. So what we did is really try to create all the explicit criteria that we knew that were out there in the literature. So that one is definitely the least common of the explicit criteria, and there's a lot of synergy and overlap between all three of those lists. So really it's another list which looks at those kind of what would be established potentially inappropriate medications among older patients.
Excellent, thank you. So I see we have another question here, which is, did you capture how long it took for the interviews and the extra med reviews, the reconciliation? Basically, did you capture all that time that you're investing into this?
I'll pass this one on.
I thought you might, Ed. This is Sandra. Yes, we are capturing the amount of time that our patient interview requires. So when we are at the point where we have a targeted list of medications with the potential for deprescribing, and we sit down at the bedside with the patient and or their respective family member and have that discussion to get their buy-in, we are capturing the amount of time that requires. In our VA study, we're also capturing the amount of time that is required to reach out to outside pharmacies for refill history as well. Some of the other components are a little bit difficult to time discreetly because provider phone calls, for example, there's often a lot of back and forth where we reach out to the provider and leave messages, and then we have to wait for them to get back to us, or it requires multiple phone calls at different points in time. So it's a little bit more disjointed. So it's been more challenging for us to capture the total time spent on that component.
Great. Thank you, Sandra.
Sure.
So we have another question here. That is, how frequently are the patient's prescribers accepting the recommendations to deprescribe?
So we don't know yet, just because this is a, I can speak prior from the pilot, but I personally don't know. I'm really interested to find out what the answer to that question. I think that's really one of the primary outcomes of this is to understand what proportion of these are actually accepted. In our pilot, I'm trying to remember, but it happens, but I would say the majority of our recommendations were accepted by providers when we made those recommendations. And in terms of common drugs, once again, just based on our pilot information, as well as there's a little bit of information out there in the literature about which medications are most successful. And there's kind of two ways to think about it. There's what's the most common medication that's deprescribed, and then there's among those that are deprescribed, which ones do you have the most success with deprescribing? And so some of the more common medications really do come down to things like diabetic medications, antihypertensives, pain medications, gabapentin, trazodone, sleep medications. But how successful we are with each of those is variable, and what's been shown in literature. So it might be a lot easier to stop a multivitamin than it is to stop a benzodiazepine among your patients. And so we'll be really interested to look at that outcome as well.
I think a lot of us will be very interested in hearing what you find. It's tough. We do have another question here, which is again about this experience of reaching out to the providers. What has it been like actually to reach out to the primary providers, the regular providers, and also the SNF providers?
So do we have any in the other room, any callers?
Did you want us to respond to that?
Yeah, I wasn't sure if there was an NP or in the other room.
We do have one of our pharmacists from our VA trial in here. I would say the SNF, I'll just answer part of that question. I would say generally speaking, the SNF providers are, the hospital treatment team is certainly the easiest for us to interact with because we can do that, in person in real time in our own institutions. And then the SNF providers are also relatively easy for us to reach out to because we, at least for the ShedMeds trial, have, this pre-established group of 22 partner facilities. So we've been working with them for a while and they know who we are and why we're calling. The outside providers are definitely, I would say, the most challenging because those can vary from primary care physicians to specialists. We may or may not be able to speak to them directly. Sometimes we speak to their nurse practitioner or the pharmacist in their office. So I would say, generally speaking, it's incredibly variable in terms of what those conversations look like and how successful we are, which is why we're trying to document the barriers and enablers, you know, how that conversation goes. And if they agree, you know, trying to quantify why they agree, whether it's they agree with our clinical rationale or they're sharing other clinical information that maybe wasn't in the record, or if they disagree, trying to document the reasoning for that as well, so that we can learn more about knowledge gaps and how to frame these conversations in a way that is effective for everybody.
Thank you. Yeah, and we have a follow-up question here from Kelly Allen, which asks, do you have any tips for getting the providers to actually buy in?
Yeah, I mean, I think that we have a real distinct advantage with regards to deprescribing as part of this trial, and that's really we have our patients as a huge advocate. So one thing that many of the people that we may talk with, they just don't have the time or the opportunity to focus on this. And so we've already done the hard work of talking with the patient and understanding what is their adherence. So sometimes a provider may not know that the patient isn't taking the medicine because they can't afford it or because it's too frequent. Or they may not know that they actually don't want to hurt their provider's feelings that it's just not working. And so having that kind of independent assessment from patients can help those conversations. Another thing is we're very deferential and cautious. We don't want to hurt any feelings. And we have a lot of conversations in terms of really kind of in talking to the patients as well. That notion is so many of these medications, we go in with the assumption that this medication was prescribed for the right reason when it was prescribed. However, we're really good at starting things and we're not good at stopping things. And so although that PPI might have been the right medication at that time, we're not sure if it's the right medication now, either because the patient's changed or the condition has changed. And so just really trying to bring to light the fact that there's been some time that this has happened and it might be appropriate to deprescribe. And then finally, just with regards to that some of the medications we're deprescribing, some of them are potentially inappropriate. We can go with some confidence and evidence saying, we don't think this is the right medication. They were admitted with a fall and they're on 4 fall-related medications. However, there are medications, I was just having a conversation recently about a statin drug in a patient, and the question was just to deprescribe the dose, and there was unclear about whether it was benefit or harm. It's like, well, for our trial, if there's equipoise, if we don't know what the right answer is, we're going to try to deprescribe so we can reduce the medication burden, so maybe we can improve adherence, and maybe that medication, we don't even know what the impact is on the outcome. So we try to have those conversations of that hey, you don't know what the right answer is, neither do we, and that's why we're doing this trial, so we can better understand what happens when we stop this medication, and we'll have more answers for you to make a better decision down the road.
Excellent, thank you. We have one last question here from Nancy Smith, which is, other than the provider call, is there any wraparound approach to informing the prescribers in the community about your research and deprescribing, grand rounds, newsletters, any other outreach that you're doing?
So right now we're kind of in the thick of things, and so we haven't. This is really, I think, our first real kind of outreach beyond Vanderbilt per se, and so we're excited to do that. And but definitely, I think that we're hoping to find out. I think one of the big purposes of this trial is there's not a lot of Medicare, Medicaid support for practitioners to do deprescribing because we don't know necessarily if it's the right thing to do. Does it actually improve outcomes? Can we actually reduce the burden of medications? And I think that if, we don't know what we're going to find, but if we find that's the case, then I think we'll have a lot of important information to disseminate about the importance of doing this deprescribing. But I think for those medications which are potentially inappropriate, which there is pretty good evidence, I think there are still opportunities for us to do more.
Well, thank you to the presenting team and to all of the attendees. There is a recording of this webinar that will be posted on the U.S. Deprescribing Research Network website. Also, look for an evaluation survey that will be emailed to you shortly. Please note our next webinar is Tuesday, March 3rd at 2 p.m. Eastern Time with Dr. Carolyn Thorpe of the University of North Carolina, Chapel Hill, and the VA Pittsburgh Healthcare System, who will be presenting on leveraging real-world healthcare data to examine deprescribing medications of questionable benefit in older nursing home residents near the end of life. And please register through our website. Thank you and have a great rest of your day.
Thank you all.